I'm a nurse, and I've been documenting something at my hospital that could destroy lives, but staying silent might cost more. I need to get this out somewhere because I'm losing my mind and I can't talk to anyone without risking everything. This is my burner account. I'm an ICU nurse at a mid-sized hospital in the Midwest. Been doing this for 8 years. I've seen the hardest parts of this job and made peace with them. But what I've been noticing over the past 4 months is something different. Something that makes me physically sick when I think about it. It started with a patient I'll call Mr. Chen. 58 years old, came in with pneumonia, standard case. Dr. Reeves was his attending. Now, Dr. Reeves is one of those doctors everyone loves. 15 years at our hospital, volunteers at free clinics, always takes extra time with patients, remembers their kids' names. The kind of doctor you'd want for your own family. Mr. Chen was improving. His oxygen levels were stabilizing, fever coming down, lungs clearing up. Standard recovery trajectory. Then on day 6, Dr. Reeves ordered a medication adjustment. Changed his antibiotic protocol to something unusual for his presentation. I remember thinking it was odd, but I'm a nurse, not a doctor. They see things we don't, right? Mr. Chen's condition deteriorated rapidly 12 hours later. Despite everything we did, we lost him that night. The outcome was ruled as complications from septic shock. These things happen in medicine. Pneumonia can turn deadly fast. I signed off on the charts and tried not to think about it. Then it happened again. Different patient, similar story. Mrs. Goldman, 63, post-surgical recovery, doing great ahead of schedule actually. Dr. Reeves was her attending too. He made a medication change on day 4. She had a severe complication 36 hours later. Despite aggressive intervention, she didn't make it. I started paying attention, really paying attention. Over the next 3 months, I counted 7 patients. 7 people who were on clear recovery paths, all under Dr. Reeves' care, all had unexpected medication changes, all had fatal outcomes within 48 hours of those changes. The outcomes were always attributed to complications, comorbidities, the unpredictable nature of illness. And those explanations make sense on paper. These were sick people. Sick people can deteriorate even when they're improving. It's the cruelest part of medicine. But 7 in 4 months felt wrong. I started keeping notes. Not in the official system, just in a notebook I keep at home. Dates, medications, outcomes. I'm not even sure what I was looking for. Maybe I wanted to prove to myself I was being paranoid. Then I noticed something else. All 7 patients had one thing in common besides Dr. Reeves. They were all uninsured or underinsured. Medicare patients with significant gaps, people paying out of pocket, one undocumented immigrant. Not a single one of them had premium insurance. I told myself it was coincidence. Poor people are sicker, have worse outcomes, less access to preventive care. That's just healthcare inequality, not something more sinister. Right. Last week I was filing some paperwork, and I accidentally saw something I shouldn't have. Dr. Reeves' office door was open, and there was a document on his desk, a letter from the hospital administration. I only saw it for a second before I realized I shouldn't be looking, but I saw enough. It was about bed efficiency metrics and resource allocation protocols, and Dr. Reeves was being commended for his excellent management of resource-intensive cases. Our hospital has been hemorrhaging money for 2 years. There were layoffs last year. They cut the night shift staff by 30%. They eliminated our mental health liaison program. Every department meeting is about costs, efficiency, doing more with less. We're not alone. Half the hospitals in our state are barely staying afloat. ICU beds are the most expensive resource we have. Keeping someone in the ICU for weeks can cost hundreds of thousands of dollars. Money that uninsured patients will never pay. Money the hospital will never recover. I went home and looked up the 7 patients in our system. I have access because I was involved in their care. Their total ICU days before the fatal outcomes, 67 days combined. I looked up the average ICU cost in our region, about $8,000 per day. That's over $500,000 in ICU resources. I haven't slept properly in 5 days. Because here's what I keep coming back to. What if Dr. Reeves isn't doing anything intentionally harmful? What if he's just a doctor in an impossible situation, making impossible choices? What if he looked at those patients and did some kind of cold calculation? This person can't pay. They're taking a bed that could save someone else. Someone who can pay. Someone whose treatment won't bankrupt the hospital. What if he thinks he's doing the right thing? Saving the hospital so it can keep saving people? Or what if I'm completely wrong? What if these are just coincidences, pattern recognition gone haywire, and I'm about to destroy an innocent man's life and career because I've watched too many medical dramas? I pulled every file I have access to. Dr. Reeves has been at this hospital for 15 years. I went back 3 years, as far as I could without raising red flags in the system. The pattern isn't consistent in the earlier years. The uptick in unexpected negative outcomes under his care started about 8 months ago, right after the hospital announced potential closure of our ICU due to budget constraints. Right after Dr. Reeves' own mother passed away. I remember because he took 2 weeks off and came back different, quieter. He'd lost weight. Someone told me his mother's end-of-life care bankrupted her, that she'd refused treatment toward the end because she didn't want to leave him with debt. I did something yesterday that could get me fired. I accessed Dr. Reeves' employee records. He's being paid $380,000 a year, but his personnel file shows financial hardship documentation from 6 months ago. He's apparently supporting his mother's nursing home costs for his father, who's now in memory care. He's got 2 kids in college. There are notes about him requesting additional shifts, asking about moonlighting opportunities. The man is drowning financially while working at a hospital. That's drowning financially while treating patients who are drowning financially. But none of that excuses what might be happening, if that's what this is. This morning, Dr. Reeves asked me how my sister was doing. I mentioned she was struggling with unemployment 3 months ago, and he remembered. He remembered this tiny detail about my life. He bought a box of donuts for night shift last week because someone mentioned we were having a rough month. He stayed 4 hours past his shift on Tuesday to sit with a patient whose family couldn't make it in time. How do you reconcile that person with someone who might be making these choices? I have 3 options as I see it. Option 1, report this to the hospital administration. But what am I reporting? A pattern that could be coincidence. Medication changes that were within his authority to make. If I'm wrong, I've destroyed the career of a good doctor during a nursing shortage. If I'm right but can't prove it, he continues and becomes more careful. Option 2, report this to the police or state medical board. Same problems as option 1, but now it's public. His name will be in the news. Even if he's cleared, he'll never work again. And if he's innocent, I've ruined an innocent man's life. Option 3, do nothing. Keep watching. Gather more evidence. But while I'm gathering evidence, if I'm right, people's lives are at risk. Lives that might be saved if I'd spoken up sooner. There's also option 4 that I haven't said out loud yet. I'm wrong. I'm completely wrong. These are just the normal tragedies of healthcare, and I'm seeing patterns because humans are wired to see patterns even in randomness. In this option, the greatest harm I can do is exactly what I'm contemplating, destroying a good doctor during a mental health crisis of my own. I printed out my notes last night, all of it. Names, dates, medications, outcomes. It's sitting in an envelope in my car. I've written addresses on 7 different copies: hospital administration, state medical board, police department, FBI, 3 different newspapers. But I haven't mailed any of them. Because this morning, a new patient came into the ICU. 23-year-old kid, car accident, severe internal injuries but stable for now. He's going to need weeks of intensive care, maybe months. I checked his chart. No insurance. He's a DoorDash driver, no employer coverage. Dr. Reeves is his attending physician. I watched Dr. Reeves examine him this morning. He was gentle, thorough, explained everything to the terrified kid in clear terms, held his hand for a moment before leaving the room. Then he stood outside the room for a long time, just staring at the chart. I don't know what he was thinking, but I know what I was thinking. Is this kid going to be number 8? I'm scheduled to be this patient's primary nurse for the next 4 shifts, which means I'll see every medication order. I'll be there for every change in treatment. I'll be the last line of defense if something goes wrong. Or I'll be the witness who stayed silent. I keep thinking about something a professor told me in nursing school. First, do no harm. But what is harm in this situation? Is it reporting a doctor who might be innocent? Is it staying quiet while concerning patterns continue? Is it destroying a hospital's reputation during a healthcare crisis? Is it allowing questionable practices to continue? The envelope is still in my car, all 7 copies. I have to make a decision in the next 24 hours because there's a medication order that came through an hour ago for the DoorDash kid. It's unusual for his presentation. Not wrong exactly, but unusual. The kind of thing that makes you tilt your head and wonder. The kind of thing I've seen 7 times before. Update 9 hours later. I questioned the medication order. I did it by the book, paged Dr. Reeves, asked for clarification on the unusual protocol choice, documented everything. He changed the order immediately. No pushback, no defensiveness. Just good catch, let's go with standard protocol instead. Either he's genuinely a good doctor who made an error, or he knows I'm watching now. The kid is stable, for now. But I still have the envelope in my car, and I still don't know what to do with it. Edit, asterisk, I'm not going to respond to DMs asking me to identify the hospital or doctor. That would be a HIPAA violation and potentially illegal. I'm also not going to confirm or deny details that could identify anyone. I'm here because I need perspective, not because I'm trying to expose anyone publicly. Edit 2, asterisk to everyone saying, just report it and let them investigate. It's not that simple. Medical investigations take years. If I'm wrong, a doctor's life is destroyed. If I'm right but they can't prove it, he walks free and knows someone is onto him. If I'm right and they do prove it, I'll have to testify, and my career in this town is over either way. Small hospital communities are tight-knit. Edit 3, asterisk for those asking why I haven't talked to other nurses. I have, carefully. Most think I'm overworked and seeing patterns that aren't there. One older nurse told me quietly that she noticed something similar about 5 months ago but convinced herself she was wrong. She wouldn't say more than that. I go back to work in 6 hours. The kid is still stable. Dr. Reeves is on shift tonight too. I still have the envelope.